Good morning and good afternoon, everyone. Thank you so much for joining. I'm just going to give this one more minute for any last attendees, and then we will start the session. Thank you. Good afternoon, good morning, everyone. I hope you can all hear me. My name is Ramande, and I am from the NITAG Support Hub based at the University of Cape Town in South Africa. It's my distinct pleasure to welcome you all in joining us in our final session in this VPOP webinar series. The series was designed to strengthen the capacity across Africa for NITAGs in the areas of new vaccine introduction, prioritization and sequencing, and now also vaccine program optimization. So as we heard recently from WHO, countries are facing sudden and quite marked reductions in external health financing, with up to 40% reductions compared to what was available in 2023. And this also comes within the context of Gavi 6.0 and changes to vaccine envelopes and a greater array of vaccine candidates that are available. So across the series so far, from session 1, which began in October, we've moved progressively from understanding what prioritization and optimization are, why they matter to NITAGs, and how they can be applied in a structured, evidence-based way in real country settings. So to date, we focus mainly on prioritization, criteria selection, data and evidence synthesis, scoring of those criteria, and basically setting up a platform for robust discussion when making recommendations by NITAGs. So prioritization we've also seen as essential in medium to long-term planning, and it's helped countries align new introductions with national goals, maximize the health impact, and improve coordination. And all of these recordings from our prior sessions 1 to 4 from October are available on the niche website, and we will drop the link to that in the chat shortly. So this brings us to today's session, which is the final session on optimization with a very, very newly developed module. And optimization, as we are seeing, is also increasingly urgent within this current global financing context. In contrast to prioritization, it addresses short to medium-term needs more, such as looking at improved delivery, reducing waste, refining and improving dosing schedules to ensure sustained and equitable access to vaccines to our priority populations. And together, the two will form a continuous decision-making cycle. They're not to be seen as separate or competing. And so today's session will introduce this new optimization module, and we'll hear from the developers of the module and when they will be available and how these modules will be disseminated. And the intention is for joint use of this module by NITAGs and EPI in recognition of the close link between policy advice, planning, and programmatic implementation. So I just want to add a few housekeeping rules before we begin. You'll see at the top right-hand corner of your screen once the session starts that there's a Q&A box. We will have a dedicated Q&A session at the end of the segment. So please drop your questions for speakers in that box as the session progresses. You would also, in your registration, have seen a link to our support survey. And that survey should be jointly completed by the NITAG. So that's a minimum of the chair or secretariat and at least one other member. And this support survey is really critical so that we can actually understand what you think you need and help plan to support your needs in future. The survey will remain open until 1 week from now, so next Wednesday. So please do ensure that you've completed it, updated your details, and have responded. And with that, it is my pleasure to welcome our speakers and open this final session on vaccine program optimization. So first up, we have Dr. Tony Hawkridge. Tony, over to you. Sorry, it's actually, with that, we have Joanna Feeman from WHO HQ. And Joanna, you will speak about the module itself. Over to you.
Thank you so much, Ramonda, and good morning, good afternoon, everyone. It's my pleasure to be with you again. I will split my presentations into two today. I'm going to start by providing an overview of this question of optimization and how it builds on also the discussions we've had in the previous webinars on this question of prioritization. Unfortunately, our colleagues from the Gavi Secretariat were not able to join, but we coordinated together, and I'll also provide some perspective relevant, of course, only for the Gavi countries on the upcoming new Gavi strategy and the implications related to prioritization and more specifically optimization. So let me share my screen. I have a few slides. And I will let Raimonda flag if there are any challenges with the presentation. But let me start by going back to a recap and some definitions as well. So first of all, looking at optimization and really understanding how optimization and prioritization fit together and what are the commonalities from a country perspective, but also the differences. We've spent quite a lot of time already in the previous webinars presenting the methodology on prioritization and the importance of anticipating future vaccines introductions and sequencing these decisions on the vaccines that are not yet introduced. Optimization is actually looking at the already introduced vaccine and looking at the opportunities to adjust the products that are being procured, the schedules, the presentations, but also the target groups to maximize the impact, the efficiency, and the coverage. One example, and we'll hear the presentation from Tony on the South Africa experience. But one example is, of course, a decision to switch from a PCV13 to a PCV10 product. There are other examples as well, and I'll come back to this in a second. I think if we could summarize, optimization is really about maximizing health impact within the available resources. This means this is about considering adding boosters, adding new vaccines, new valency, or when resources and financial resources and human resources are available, but also the opportunity to adjust when the financial and human resources may be reduced. So here are some examples because we seem to put things in boxes and assume that they're always pretty straightforward, but I think it's not always the case. So we wanted to put a few examples of policy questions and whether they're actually prioritization and optimization and why. I will not, we usually do this in a more interactive way, and in the sake of time, we don't have time for this, but I want to highlight a few examples here. For example, when looking at typhoid conjugate vaccines and whether it should be introduced in place of the polysaccharide vaccines that is used during outbreaks, is this prioritization or is this optimization? It's actually considered a prioritization question because it's about an introduction of a new antigen in the routine calendar. We can take another example of adding booster doses of DTP-containing vaccines and when, and in this context, it is considered an optimization question because it's adding a dose to an already introduced vaccine to achieve better disease control. Another example would be on the decision to introduce the multivalent meningitis conjugate vaccines and when. And the question is it prioritization or is this optimization? And for the countries that already have a MENA program, then it's optimization. But if you don't have a meningitis vaccine in your program, then it should be considered a prioritization. So again, aiming here to highlight some of the subtleties in considering optimization or prioritization and how that may impact as well the process for countries to take evidence to inform decisions on these questions. So this slide is really about, again, highlighting the differences. And I think I'll just highlight that optimization is really considered about the short to medium term impact and decisions that will have an effect in the next 1 to 5 years, whereas prioritization is medium to longer term and really about sequencing and planning. Because optimization has immediate consequences and implications on the program, it is essential that EPI teams and NITAGs and their secretariats really work together. And we'll see a bit later as well that in the selection of the criteria and the consideration on the optimization process, there is a lot of programmatic implications that need to be taken into account, including on the budget space and the budget impact of these decisions. Optimization is really about assessing the trade-offs between keeping the products that are and the vaccines that are already in the program versus the opportunity to switch to another schedule, another presentation, another product. So here is an example. If we look at the evolution of the PCV program in the last 20 years, what we see here on the top row is really highlighting the evolution of products that have become available in the market in the last few years. The second row is the different presentation that became available over time for these existing products, with the 4-dose vial, 10-dose vials becoming available for the existing vaccines, as well as the evolution of the policy recommendation. And you've all seen the publication in September of the latest position paper on PCV. The bottom line also highlights the evolution of the price for the Gavi countries. So this is focused on Gavi. But I think what is relevant here is really to show that the programs and the market and the policies continue to evolve even when a vaccine has been introduced 10 years ago. So there are opportunities and really triggers for countries to reconsider their existing programs and look for potentially more opportune vaccines and presentations or schedules to adapt to their own context. So this slide really summarizes the potential triggers for this question of optimization. It also applies to some extent to the prioritization work. And what I will really highlight here is this yellow box, which focuses on optimization. And you can see here really that the strategic programmatic planning that is described in the National Immunization Strategy, and I think we'll hear from experience from countries on this shortly, really is an opportunity to consider whether there are optimization possibilities that would be relevant for your country. Of course, the availability of new SAGE recommendation, of new vaccine, new products, new presentations, as I referred in the previous slide on PCV, are important triggers as well. And for the tendering process for the countries that are self-procuring countries or procure through potentially different channels, this is also an important steps to consider. I'll spend a little bit of time now talking about this trigger that is related to the Gavi policy and highlight some of the key features of the Gavi 6.0 strategies and what this will mean for countries. I have borrowed these slides from our Gavi colleagues, so again, I'll be happy to also channel any follow-up questions from them. But I think the main point here is to acknowledge that Gavi is entering its new strategic period, so Gavi 6.0, which marks a fundamental shift in the way that countries will be able to apply for Gavi support for new vaccine programs. Up until now, countries were able to apply for any vaccine programs if they had the capacity to introduce and to co-finance. And these introductions were decided one by one with an application submitted to Gavi. As part of this new strategy, Gavi is now moving towards the establishment of those country vaccine budgets, or CVBs, which will provide countries a fixed budget, so a fixed budget envelope. And in this envelope, countries will need to decide which vaccines programs are being kept. And so these CVBs, and again, a lot of communication will be shared to the relevant countries or the Gavi countries in the coming days and weeks. So I'll go quite quickly, but I think it's really relevant to understand why optimization is an opportunity and should be considered in the short term by specifically by the Gavi countries. So these CVBs will cover the routine programs as well as the preventive campaigns, but not the outbreak response vaccines. And as part of these CVBs, Gavi will provide a set envelope that will be split into funding for guaranteed programs, which is the red box that you have here, which means that funding will be available for all countries to maintain and continue their program or introduce the vaccines they may not have in this red box. And for the discretionary programs, a set amount will be provided, and countries will need to decide how they allocate this funding that is called discretionary. This means that countries will need to take decisions on and trade-offs on what to maintain, but also potentially what to introduce, and where the notion of cost will become much more important, as countries will need to estimate the total budget for their vaccine programs as part of their country vaccine budgets. Again, this is a fundamental shift and will be shared, communicated, and explained much more by the Gavi teams, as well as all alliance partners will be part of this conversation. But I think in this context, what is really key is to understand that this vaccine portfolio optimization and prioritization, also called VPOP, will be an essential component of the process for the Gavi countries to establish their country vaccine budgets and to confirm which switches may be considered in the short term, as well as any future vaccine introductions. So in this context, and this will be my last slide for this initial presentation, WHO, along with UNICEF and with the support and the technical expertise from Development Catalyst, we've been working on an optimization tool to facilitate the process for countries to review their portfolio and consider optimization opportunities. As Ramonda mentioned, the guidance has been published just this morning. You are the very first ones to get this link. And you can see here this guidance that is now available on the NITAG Resource Center. By the end of the week, as we continue to develop this VPOP guidance, we will also include additional documents and templates, which are referenced on the slides. I will go in more details on the presentation of the tool as well as the process in the second part of the presentation. But again, highlighting that optimization is an opportunity to consider how to optimize the current portfolio and will be an essential component of the Gavi strategy, but is also relevant for all countries. This is not a Gavi process. I think it's essential to acknowledge the financial environment at the global, regional, and country level, and the opportunities that this optimization process can provide for all countries, whether they're Gavi supported or not. So with this, I'll stop my presentation, hand back to you, Ramonde and Tony, And we'll deep dive on the actual process and available resources in the second part of the webinar. Thank you.
Thank you, Joanna. I don't think there's much more to say other than to hand over to Dr. Tony Hawkridge, who will speak on the SA PCV switch. Thank you, Tony.
Thanks, Ramonde. Can someone just confirm that you can see the slides?
Slides
and
are
it's
good.
in presentation mode.
Yes.
So thank you very much to Johanna, and I should also say huge congratulations on getting the tool out in time for the Gavi announcements at the end of the week. I know there's been a lot of pressure. So my name's Tony Hawkridge. I'm giving the English version, and Imen's going to give the French version of this presentation later in the month. And we both work at Niche. I should just mention I'm not a member of the South African NITAGs. I'm really much presenting on behalf of them, Ridzani and Anne and others who've helped with this presentation. So I've only got 12 minutes, and I'm just going to tell you a story about how South Africa changed from PCV 13 to 10 and why they did it. So I'm going to start off with just showing you that in our country, before that decision was taken, there had been a lot of research into PCV over the years. I've pulled out some of the seminal papers, and there's a lot more which I can share with you. But from 2017, Cheryl Cohen's group, they demonstrated effectiveness of PCV 13 in preventing IPD in the HIV uninfected, both exposed and unexposed young children, and also trending towards efficacy in the HIV infected. 2020, 3 years later, Shabir Madi's group showed that the immunogenicity of the 2+1 and the 1+1 schedules of PCV that should read 13, not 213, or 10 was equivalent. Javed, they looked at serotype distribution, antibiotic resistance, pre and post introduction of 7 and 13, the vaccine types and the non-vaccine types. The one decreased, the other increased. Antibiotic resistance mainly decreased. Huang, they did some modeling, and those were the results. They actually advocated staying with the PCV13. Lekuleni, they looked at lineage diversity, antibiotic resistance, and highlighted the importance of ongoing genomic surveillance, and we'll come back to that. Olwagen, they looked at colonization in under fives in the various schedules and various products, didn't see differences. And the last one here by von Gottberg, which is if you just want to look at one paper, I'd recommend this one. It documents invasive pneumococcal disease over 15 years before COVID in our country. And they showed that in under twos, invasive disease declined 76%, including PCV7 and 13 vaccine types, but no change in the non-vaccine types. And then in adults and elderly, it was slightly different results. So that's the background, and obviously lots of other literature also available, but that was what was available to the EPI, as it's not just the NITAG, the EPI and the NITAG, which we call the NAGI, National Advisory Group on Immunization, at the time when this came up. So this is where the story starts. So in South Africa, we had introduced PCV7 in 2009 and PCV13 2 years later in 2011, both in a 2+1 schedule. And then in 2024, the country switched to PCV10 at the beginning of that year, and they started with a new tender. And the question is, why did they do that? They changed from Prevnar to the SII product brought into the country by Cipla. And the reasoning behind it was that it included the serotypes which were most prevalent and that it was considered interchangeable. So let's just unpack that a little bit. Our national tender process, it's a 3-year budgeting cycle with our National Treasury, and they were starting to discuss the new tender and the new product, and the EPI had a proposal, and they wanted to get advice from the NITAG. NITAG's position was that there were non-significant differences between 10 and 13, and so they could be considered as equivalent, And the department was then left to decide on which to choose based on their tender specifications and their supply chain mechanisms. The very important, we have the National Institute of Communicable Diseases in South Africa, which conducts ongoing serosurveillance for the country, and that was a key consideration. And then also key at the time, the NITAG was recommending switching from TT to Tdap and from measles to measles rubella, and obviously those have cost implications. The broader sort of financial context at the time was that we were in a bit of a budget crisis after COVID. We spent a huge amount of money on COVID, and we had these austerity measures, and that finding additional funding for Tdap and for rubella would have been very difficult at the time. We'd also had a number of deaths from pertussis in young infants, and many felt that the only way to prevent further deaths was by changing to Tdap during pregnancy. And in the end, the money that was saved by switching from Pfizer 13 to SII 10 was released into the system, and that actually was used to fund Tdap and rubella rollouts. This is just showing you the different serotypes contained in the 3 vaccines which were being considered. I think the take-home measure is that no vaccine covers all serotypes, and that whatever one you choose is going to be some serotypes missing. The question is, are those important at an epidemiological level, and are they important at a clinical level? So the decision was made to go ahead, and it needed to be implemented. This was in October 23. The intended day for the change was January 24. So they had about 3 months to work with. Our national department runs these webinars fairly frequently, not just on vaccines, but on a whole range of things. So they're called the Knowledge Hub. So they had a Knowledge Hub webinar or two where they informed participants, who were mainly caregivers, about the burden of disease, that it affects mainly infants, but also adults and older adults. They told them about the prevalent serotypes, which we've been experiencing in the country, which ones are going up, which ones are going down, which ones are staying the same. And they told the participants that the 2 products were considered interchangeable because they covered the relevant serotypes, and that based on the minimum vaccine specification provided by the NITAG, the decision was made, and we were going to be following the new tender. I gave them some practical information, particularly the different presentation of the 2 products, and then it happened. But what is very important is that it didn't happen in a vacuum. It happened in a context where there was ongoing surveillance being done around serotypes by the NICD. And so in this particular slide, you can see the important row to focus on there is the second row in table 4, the lower table. And the numbers in brackets are the percentage of serotypes due to serotypes contained in the PCV13, but not in the PCV10. And remember that the change was at the beginning of 2024. And you can see if you just eyeball along there, there was no significant change, and that's ongoing. So these figures are up until the middle of 2025. They were the most recent that I could find, but I'm sure that there are more recent figures being discussed within the NICD. And if there's any spike, that will be brought to the attention of the relevant authorities as quickly as possible. This is the same sort of data, but it's just for that 15-month period. And the color bar to focus on is the green, which again tells you, what percentage of cases you would be missing by not having 13 and by having 10. So that's a quick story, and it had to be quick, but hopefully it demonstrates. So this was an optimization decision. When Johanna put up her slide, I was thinking, is it optimization? But it wasn't new antigens. We were in fact taking away antigens, so it was a new product, but the same antigens and a couple less. But it was made. The decision to switch was made It was made by the EPI and the ministry, and it was made primarily for economic and broader public health reasons, which I've told you about. The introduction of Tdap and the switch to MR. NITAG was asked for its opinion. They did their homework and they said, okay, the two, you can consider them interchangeable. But very importantly, there was post-switch surveillance, which happened and is happening and will continue to happen. And to just be sure that we're not running into problems there, and it's freed up this funding that was used for the TDAP and the MR. So it was made, and I think this is my last point, it was made without the use of this optimization tool because it didn't exist. I think that they would have arrived at the same decision for the same reasons, but if we'd had the tool at the time, if they'd had the tool at the time, it would have had the advantage of being able to formalize it, to document it, and so that others looking at it later could understand the exact rationale underlying the decision. So that's all I want to say. Those are my contact details as well as Rudzani. And there's a whole lot more slides in the pack, which I'm not going to go through, just giving you examples of similar decisions that have been faced with PCV in other parts of the world, particularly Belgium and so on, just for interest. So thanks very much, and back to you, Ramondi.
Thanks so much for that, Tony. Right on time. So it's my pleasure also to introduce next Dr. Casey Furaha from Tanzania NITAG Secretariat and also EPI. Over to you, Dr. Furaha. Tony, I think we can still see your slides. And you are on mute, Dr. Furaha. That's great.
Yes. Okay. So hi, everyone. This is Furaha, as I've been introduced. I'll be speaking about our vaccine optimization in Tanzania and what is our approach in terms of vaccine optimization. I want to stop video sharing and then coming back to sharing my screen. Just let me know if you're able to see. Are you able to see the full screen?
Full screen, thank you.
Thank you very much. So the outline of the presentation, I'll talk about Tanzania immunization context, but I'll also go through the optimization approach, and I'll end up with, I think later on I'll end up with a Q&A session and rather clarification of some few issues that I might not be able to talk about during this presentation. I would like to acknowledge members of our NITAG, the EPI staff, including the program manager, who are all present in this webinar. So to start with, Tanzania has about 13 antigens with a growing number of products together with formulation that has been coming to the country. But also there's also global and domestic financing, which is under pressure of trade-offs, as well as required under the new funding models, as someone has spoken initially. And of course, immunization performance gains have stagnated for some time, but we also still want to reach a zero dose, hard to reach areas in terms of providing equity, and also outbreak resilience remains our priority in Tanzania. So we have started discussions on issues of optimization. And among other things, Tanzania plans to do evidence-based decisions, which involves data analysis in terms of disease burden, but as well as also identification of risk population. And at the same time, we also want to review our vaccine performances in order to guide which vaccines are to be prioritized in terms of optimizing within the national program. And we wish this all to align with vaccine choices and also national health priorities, but at the same time, being able to ensure that cost effectiveness is being thought of and is able to be well integrated into the existing immunization policies. And we know for sure in doing that, we need a strong coordination between the Ministry of Health, but as well as partners in order to support the vaccine optimization. This we've already started in terms of the IVD or the EPI program being the major central part for coordination. In terms of immunization system strengthening, of course, we are doing this for the purpose of course, improving cold chain and logistics, but at the same time, reducing wastage. And also, we are also considering very much issues of healthcare workers' knowledge in terms of capacitating them, trainings, but as well as involvement of the community engagement. And for that, for sure, we need to also have a sustainable and efficient impact of immunization program, and with the process conducting of comprehensive reviews of Tanzania existing vaccine portfolio, but as well as identifying and prioritizing key optimization questions in terms of vaccines to be introduced and also optimized. Assess optimization options, such as using a transparent multi-criteria decision analysis and approach between the program as well as the immunization technical advisory group, but as well develop evidence-based, feasible and sequenced optimization recommendations that are able to align with the national immunization strategy, as well as the HSSP 6 and the, for sure, Gavi requirement. So for that also, in terms of approaching, we also want to think of monitoring performance, as well as the safety monitoring once we are doing the optimization, also tracking things that are going on during that particular time. And we thought of having monitoring and evaluation as central to vaccine optimization. We want to use the data, routine data, to track the coverage, being able to make sure that equity and safety is being considered, but as well as also looking at what is happening in terms of vaccine preventable disease surveillance. We want to see where there's a good coverage. Also, these vaccine preventable diseases are lower compared to initially where we're also seeing some outbreaks of some diseases. But the most important part is also to strengthen the vaccine safety surveillance systems by monitoring the adverse event following immunization before, during, and throughout the process of vaccine optimization. And we hope that the data-driven approach will also allow timely improvements, but as well as support better health outcomes and efficient use of resources. What is the timeline for what we want to do? We're expecting to start much of the vaccine optimization in March 2026. We thought of that because as we spoke about 2 weeks ago, we did not have the guidance and we are told it's coming out. So we thought maybe we should just push it a little bit further up to March 2026, starting March 2026. We are very happy that the guidance is out and further details will be coming at the end of this week. So I believe the program together with the TITAG will start planning on that. But as it has been mentioned initially, we have plans in terms of short terms, but as well as the medium and long term. And when you talk about short terms, what can be done within the first few months, not preferably within the first 6 months. And that is, we want to review the guidances, setting priorities, but also engaging stakeholders, and also going through the issues that we've spoken initially about looking at the burden of the disease, logistical issues, as well as the cost effectiveness of what we want to optimize vis-a-vis what was there before. But in terms of medium and long term is for sure strengthening of delivery systems by looking at what has been done in terms of improving the cold chain system, strengthening by training of healthcare workers, but also increase community engagement and performance of routine data. As a long term, what has been happening in terms of the things that we want to adjust, but also during that particular time, make adjustments if there are any needed for the purpose of improvement of and the better health outcomes in terms of immunization service delivery. So we had this discussion prior. We had started with a vaccine prioritization initially. And during that particular sessions, we also thought of what we'll be doing in terms of vaccine optimization. And during that particular meeting, we had a discussion of maybe 4, 3, 5 issues. And one was in terms of the IPV. We are only giving 2 doses now at 14 weeks and 9 months of age. But we thought of optimization in terms of looking at the 3rd dose, but also looking at a fractional dose. And also, what do we think about introducing hexavalent? Currently, we're using a pentavalent and adding up the IPV, 1 IPV to make it hexavalent. In terms of MR 10 to 5 doses, this has been a discussion for quite some time. In Tanzania, we have Tanzania mainland and Zanzibar. Good enough for Zanzibar had already introduced the 5-dose MR vaccine, but for the mainland, we had not introduced yet, but plans had started last year, and we are going to probably introduce in the next few months. once we have settled every issues and also had a implementation plan. The other vaccine that we thought of is the BCG vaccine. Currently, we are providing BCG vaccines to all the newborn babies. And it was a part of a discussion is, do we want to look at a lower dose vaccine? As we speak now, we have BCG 20 vial dose. Is there any possibility of going to a lower dose vial? That is one, but as well, what is the burden of disease in terms of tuberculosis, especially in the first 2 years of life where the vaccine is protective? Should we do that in all the kids in Tanzania, the BCG vaccination, or should we just do it in subgroups of children in the country? But as well as also we thought of DTP containing vaccine as the booster dose at second year of life, but also looking at the HPV vaccine in terms of valency change. We are now using the Gardasil 4. What about looking at going to a 9 valency? But also looking at what is the burden of disease in terms of when we want to see older age groups, means girls, but what is literature and some studies talking about in terms of boys. So this is just a preliminary discussion that we had between NITAG and the EPI, but we also thought of doing further sort of tracking or receiving data through surveys from NITAG members and other stakeholders within the program and outside the program, stemming through immunization in the immunization family. So that, in summary, is what I have for today. But I would like to stop here and say thank you so much. Over.
Thank you so much, Dr. Furaha, for sharing your Tanzanian experience. We will now go back to Joanna for the second part on optimization. Over to you, Joanna. Thank you.
Thank you so much, Ramanda. Hi again. And thank you so much to Dr. Furaha and to Tony as well for sharing these experiences, which really provide some good context for the presentation I will give now on the actual guidance and the process for this optimization work. I have a few slides that may seem a bit technical, but I think I really want to deep dive on the different aspects. And I will start by this view, which really summarizes the process for decision-making on optimization. This is based, you're familiar with this funnel view because this is aligned with what you have seen in the new vaccine introduction and prioritization sequencing tool. So this is really the same approach of adapting your framework, having this 3-phase approach. The second phase is about assessing appraisal, optimization, and sequencing. And the final phase is about the recommendation. So I will start and deep dive really on this framework adaptation and what resources are available as well to help you with this process. And then I'll touch on the second phase and an example of the recommendation as we go along. I think what is really important is to understand that this approach is about identifying your preferred option and building on a formalized process, evidence-informed, to develop recommendations that are country-owned, reflecting of your country, and based on a consensus. So this approach is described really in this 10 steps. Sometimes when you open a guidance, it all seems quite complex. But it is really, again, a 3-phase approach that can take, about 3 months with the relevant resources available and the ability of the NITAG to meet with the EPI team through these workshops that are mentioned here. But you can see here that this is a really 10 steps process, which is about reviewing your current portfolio, selecting the optimization questions that are relevant to your country, and to review and select 10 criteria for these different questions that will help you assess basically the different options that are available. The data collection will be an important part to be able to prepare the content for the easier comparison of the different options. And the second phase is really about ranking for each of the optimization questions that you will consider to make recommendations on which ones to choose, which ones to discard, to compare the questions and define what are the priority level for each of these questions, define the programmatic budget and constraints to take into consideration, and then finally to draft those scenarios based on this whole process and that can be consolidated in a second workshop. So again, a very similar approach to what you have seen as part of the NVIPST. But the starting point is different, of course. The objective is really to start from your current portfolio, listing the vaccines that are currently available, to perform a fiscal or budget space analysis to understand the overall cost of your program and the budget space that is available, to also understand what are your opportunities to optimize and what are your primary objectives. I will go through the next steps in more detail, but we have mapped the list of all the potential questions you can consider when thinking of optimization, and that can guide you in the selection of the relevant question for your countries. We have then developed some fact sheets that again give you an overview of the potential impact and implications from a programmatic standpoint that can help you define the questions to be further assessed. And again, this is where you will also discuss which criteria should be selected to collect the evidence and then to be able to compare the different options. So if we look at an illustrative example of a potential schedule and overall portfolio in a country, you can see here what the current schedule look like. And what we've done, as I mentioned, is map all of the different vaccines and what are the potential opportunities for optimization. So for HPV, there's an opportunity to change serotype composition, but also a schedule change, a target population change, and to change for other products. Sorry, this skipped a little bit quickly. And you can do the same approach for all of the different vaccines and understand what are the potential opportunities based on the products that are available, but also the recommendations on schedule. So in this particular case, for example, if we look at the schedule, this country currently has introduced HPV, it's in their portfolio. They are using an HPV-4 product and they're using 2 doses. We know there are potential opportunities around the HPV to switch to a different schedule with a recommendation on a single dose, and there are other products available. So this could be one of the questions to consider. On the measles rubella, we can see that the country is already using a 10-dose vial, and there are recommendations for and opportunities to switch to a 5-dose vial. This is something that could also be considered. On the PCV program, we can see that it's a 3-dose schedule organized at 2, 4, and 9 months, and we know there are opportunities to review so this 2+1 schedule and to switch potentially to a 1+1 schedule. So this could be considered. This is based on the latest WHO recommendation and under conditions. We also know that there are other products than the Pfizer PCV13 available, and we've heard from Tony on the experience from South Africa. So this could be reviewed. We can see here as well that the countries is Penta and IPV, but in this particular case, the country is already planning to switch to hexavalent, and that has already been decided. So this would not be considered as part of the optimization process. I think what I learned really from the experience from Tony is that even without the guidance, there was really an opportunity to review optimization opportunities for PCV, but the potential impact on introducing other vaccines. So this is one key takeaway of how a full portfolio review can enable adjustment for a specific program, but also on the other antigens that are introduced by the country. So as you saw in the slide that I presented on the guidance, we have mapped these optimization questions. This will be available by the end of the week. And we have developed here an overview of, for each of the programs for HPV, we discussed the opportunity to switch to a lower valency, the opportunity to change from a 2-dose to a 1-dose schedule, as well as the opportunity to change product. So we've mapped here, if a country was to look at the impact on the budget, these are really the 3 options that would be considered. And we've added the information on the type of Gavi program, whether there are case studies available, and we've also included some perspective on how complex is the implementation of the switch. The methodology to make this assessment is defined and detailed in the guidance and will be available as well. So if we take, for example, the change to a lower valency or a change from a 2-dose to a 1-dose, you will see that we've added the WHO recommendation as a reminder of the latest policy recommendation. And then we have detailed here what are the opportunities, what are the products under consideration for this specific optimization questions, and then what are the potential impacts. For a country being on HPV4, we know that the publicly available prices are mostly reported as lower for HPV2. So this is potentially a positive impact on the budget and the overall cost. There's no change on coverage, on cold chain equipment, on wastage. There seems to be no supply constraints reported on HPV2, but of course this needs to be further assessed and confirmed. And then in terms of the disease control, we see that the serotypes covered by an HPV2 product is reduced, but at the same time, the optimal protection is maintained by covering HPV 16 and 18, which are the ones causing the majority of the cervical cancer cases. There are no changes at the patient's level, at the HR level. And then when we look at the programmatic implications here, there's no new contact point needed, no change, major change on the documentation. You may need to update the vaccine name if recorded. There's minor training that needs to be conducted with new vaccine documentation. There needs to be some communication about the continued protection. Again, the supply chain investment, depending on the product, there may be some adjustment needed. And there are surveillance investment that may be needed to monitor for potential type replacement. So these are the type of information that we aim to provide as an overview, and that needs to inform the process for a full assessment based on your country context. We have listed here the proposed criteria for you to assess more detail the actual opportunity to switch to a lower valency, and that can be detailed and is part of the full list of criteria that will also be available on the NITAG Resource Center. We've mapped some key resources here, as well as examples of implementing countries. We know that Denmark and Malaysia, for example, are countries that have done this. Here is another example for a change from a 2-dose to a 1-dose schedule. You can see that we've adapted the feasibility here. We've adapted as well, of course, our potential impact and programmatic implication. we can see that a change from a 2-dose to 1-dose schedule would have a major impact on the budget, since you half the number of doses needed. There are opportunities to integrate with campaigns, positive impact as well on the cold chain space with the reduced volume, the lower systematic wastage, the fewer injection with the patients, a simpler schedule, less workload for healthcare workers as well. And you can see here again the list of criteria that has been adapted, and information on actually the number of countries that have switched to a 1-dose regimen, with 81 countries as of December 2025. Again, we've added the resources here, and you can see again all of the potential implications. These fact sheets are not meant to be the end of the process and the data collection process, but rather the beginning, and to help you in the selection of potential questions that you would want to consider based on your country and your own portfolio. The output of this work should be a list of the preferred option for each optimization questions, backed by strong evidence. And here is an example of what it could look like. I really want to emphasize as well the importance of the consensus building process and the recommendation that will result of an evidence-informed process led by NITAG and EPI, and that will facilitate as well the justification of your potential switches when discussing with external stakeholders such as donors, partners, but also manufacturers. I think it's an important process to really justify how those decisions may be taken by countries, and how the evidence has informed this assessment of trade-offs. So again, I think I will finish a little bit earlier than planned, but highlighting that the guidance is available. The optimization questions and fact sheets that I showed you in this presentation will be available by the end of the week, as well as a number of templates. We will continue. This is a first presentation and introduction to the guidance. We are working in close collaboration with key partners and immunization stakeholders to ensure that we will continue to disseminate information, to build capacity on this process, and to engage with NITAGs to support their work in this VPOP approach for all countries. As I mentioned, this is not a Gavi-specific process, and you will find relevant information also for the self-procuring countries in this guidance. So with this, I will stop here and hand over back to you, Ramonda, for additional questions.
All right, so Johanna, thanks very much. Can you hear me? Okay, my name is Gregory Hussey. I am from the NITAG Support Hub here at the Vaccines for Africa initiative at the University of Cape Town, and I will just moderate the last session relating to questions to our three presenters, and they were really excellent presentations. And thanks, Johanna, for introducing the topic of optimization and its comparison with prioritization, and then taking us through the toolkit, which I think everybody is looking forward to use moving forward in terms of their own country experiences. And Furaha, thanks a million for sharing with us what is planned for in Tanzania. I have a specific question which you could just note in the meantime. Are you planning to utilize the current toolkit moving forward as well? But be that as it may, we'll come back to that in a few minutes. And then, Tony, thanks very much for sharing the South African EPI experiences with respect to pneumococcal vaccine. So let's open the floor for discussion. I saw that there was one question on the chat earlier on, And I think that was related to the issue of prioritization, optimization, and outbreaks. I'm not sure. That question seemed to have disappeared. Salim, was that noted?
Yes, it was noted. I'll put it up on the screen now. I think Tony did respond to it,
But maybe,
but we can look at it
you
now
could
again.
we could just put it up again so that
I tried to
that
answer it, Greg. It was Mohammed, and it had two parts to it. How can countries leverage guaranteed programs to strengthen routine immunization while strategically using discretionary programs to address emerging and outbreak-prone disease risks? And the second part was how can disease surveillance burden data and cost-effectiveness evidence better inform prioritization between guaranteed and discretionary immunization programs? So my comment was good questions are not easy to answer, but I talked a little bit about balance and compromise and the importance of being transparent and having everything documented and being defendable. But I think it might be a question more for Johanna. It was at a sort of strategic level.
Johanna, would you like to comment? Or
Thanks.
Laura? Laura, I see your hands up. Do you want to comment on that? Or shall we take Johanna first?
Go ahead, Joanna, and I can compliment. Go ahead.
Thank you so much. I mean, I think this question of guaranteed programs versus discretionary programs is going to trigger a lot of questions. There are additional parameters as part of the Gavi 6.0 strategy that are not covered in this presentation, including on all of the outbreak response, fragile settings. And so I think there will need to be additional communication that will be coordinated by the Secretariat on all these aspects. But in terms of the question here about strengthening routine immunization, of course, the process that we outline here aims at supporting countries in planning for how to allocate their resources within their programs. And I think this question of future new vaccine introduction is clear, and we are continuing to comment on how optimization is also an important component to ensure that the program is optimized. We focused here very much on the potential switches around HPV, but there are also opportunities to really strengthen the programs themselves, increasing coverage by adjusting the schedules. And so this is part of the overall conversation. The current financial constraints really put an emphasis on opportunity for cost reduction, but this is not the main focus of optimization. As I mentioned, it's really about maximizing the health impact within the available resources. And so the opportunity to focus on the hexavalent as part of the guaranteed program to address some of the potential challenges related to polio is one aspect, but overall, it is fair to say that optimization can really be taken into consideration to improve basically the program coverage and to consider opportunities in the mid to short term. But Laura, do you want to add on this as well?
Yeah, thanks so much, Joanna, and thank you for this question. It is an important consideration particularly for countries that are Gavi relying on Gavi resourcing to complement their programs. Just wanted to add that an important aspect, and thank you, Mohammed, for the question, is also being able to link with the national immunization strategy moving forward. As Tanzania, as Dr. Faraha nicely mentioned, they're looking at their prioritization, their optimization, and also readjusting their national immunization strategy as a complete process to move forward. And this is where aligning what is in the routine program and covered through the annual budget and cycle, as well as the multi-year cycle, and being able to consider what's going to be discretionary for these outbreak-prone diseases that might require either specific subnational campaigns or potential for periodic intensification of routine immunization. These are additional strategies now that need to be considered in those national immunization strategies, along with the prioritization and optimization to look complete, to have a complete picture of what might be needed for really being able to maximize these efficiencies. So it is a large and important discussion that also needs to include surveillance data. It needs to include geographic pertinence, for example, where you know you might have a susceptibility for outbreak because the disease burden data or the recent surveillance data are showing you that you have emerging potential for additional outbreaks. So this is where having all of the prioritization, optimization, and national strategy considerations together between your NITAG, your EPI program, your immunization program, and your interagency coordinating committee is very important so that you can combine your resources and find these efficiencies for the program, particularly given potential reduced envelopes from Gavi moving forward. Thanks. Thanks, Greg. Back to you.
Thanks, Laura, and thanks, Johanna, in terms of your responses to that. Earlier on, there was a hand up by Lindiwe Maku. I'm not sure. I can't see if the hand is still up. Lindiwe, did you have a question? If not, maybe we could come back to our Tanzania colleagues, Dr. Ferrara. Just in terms of this new tool, I mean, obviously you people have been thinking about optimizing your immunization program for some time now. I know you probably haven't had a chance to look at this new tool. And Johanna, it's a question to you as well. I mean, has the tool actually been piloted, for example, in our region here in Africa? But Dr. Farah, just in terms of what you've seen, do you think this tool would be of some use to you moving forward in terms of your plans?
Yes, thank you, Anthony. Thank you, Greg. Yes, that's the plan of using the tool. So we had an introduction, just a brief introduction of the tool, but unfortunately we were not able to see the whole guidance as it wasn't out. But the plan was to use the tool once it's out.
Okay, that's excellent. Johanna, just coming back to you. I mean, has the tool been? You mentioned Denmark. Was that and Indonesia or Vietnam, but was that specifically in relation to HPV or was it in relation to the tool?
Thanks so much, Greg. So the example that I showed was really specifically on this question of a switch to a lower valency, so from HPV4 to HPV2.
Okay.
And we aim to provide perspective because we know it's important for countries to understand whether this is a decision that has been made by others or not, and what were the factors. So there's really also a component of information sharing and peer learning that is important. In terms of your question, and I'll just pull back my slide back up. So as I mentioned, this guidance is really brand new, and we are consolidating the additional complementary document. We are currently working with a number of countries as early adopters, and we will update and consolidate a full VPOP toolkit by Q2, building on the learnings from these early adopters. So there may be some slight adjustments on the recommendation or on the templates based on the feedback that we will hear from countries. This work has started already with 2 to 3 countries, and there are another number of countries that are interested in the African region. We are working closely with our UNICEF partners, with JSI, as well as Development Catalyst, to really bring those learnings together and coordinate to inform the finalization of the guidance. So those learnings are being captured in February, March. And I may say as well that there will be a new SAGE session on this question of VPOP, vaccine prioritization and optimization, in March this year. So there will be also some documentation presented there. Thank you.
And I would assume that since the tool will be available through the NITAG Resource Center for us to, in a sense, play with it. I mean, comments would be welcome from potential players and especially NITAGs, just to see how it moves forward. All right, thanks, Joanna. I think there are 2 or 3 questions in the Q&A from Georgina. What assurance are in place to guarantee sustained vaccine availability when optimizing from MR10 to MR5 dose presentations? And Joanna, I see you typing an answer.
I started typing the answer, but maybe I can just comment. So this is indeed like an important part to consider the implementation of the optimization decisions and when countries decide to switch. I think we really need to also acknowledge that from a timeline perspective, it may take some time to actually implement the switch because of vaccine availability and the ability to secure the new product. So in the case of the MR 10 dose to a 5 dose vial, there's been actually a lot of work coordinated across partners, including UNICEF Supply Division, on managing this overall project and coordinating across the different actors so that the demand from countries would be fully understood from the procurement perspective so that supply could be available for the countries requesting this switch. But in any case, what we really recommend is to ensure that once the recommendation is made in coordination with the NITAG, that the EPI team really follows up for those procuring through UNICEF with UNICEF Supply Division, for the Gavi countries with their Gavi focal point, to ensure that there is clear next steps on the implementation of the switch and avoid any potential challenges due to vaccine availability.
Thanks, Johanna. Then there's a question from Stephen, and it's related to switching of vaccines. What is the impact of a vaccine switch, especially when the change occurs after a child has already started a primary series with a different vaccine strain? Tony, do you want to comment or respond to that question?
I was going to say that was a question for Professor Hassi or Professor Kugina. That's higher
okay.
grade immunology.
I'm trying to pull you in onto the conversation, Tony. But
Ben
Stephen,
in the audience.
No, I'll respond to Stephen. Stephen,
Okay.
generally speaking, when there is a change in terms of the vaccine, there usually isn't any problem in terms of using that vaccine as a replacement for the other vaccine. So, for example, in the case of South Africa, we've switched from a 13-valent to a 10-valent pneumococcal vaccine. If the child had received 2 doses of the 13-valent vaccine at 6 and 14 weeks, we give the booster at 9 months of age. And if there's no more 13-valent pneumococcal vaccine available, we would then give the 10-valent pneumococcal vaccine. All right. Any other questions? I can't see any hands. There is a hand from Benjamin. Benjamin? You want to add on to the issue of vaccines?
No,
Last question.
You've answered, Greg, and I think another example is on whole cell pertussis and acellular pertussis that we have had experience of in South Africa. But I wanted to ask a question to Johanna in terms of the optimization. I think if we look at the tools that are currently available, so before the NVI PST tool, we've had the E2R. And for us partners supporting NITAGs, we picked up the challenge of many NITAGs being able to follow this process. Now we add another tool, NVI, and now we're adding another toolkit, which is optimization. They're all great. But the question is, do you think we also need to optimize the current framework for countries to tap into NITAGs to aid in decision making? We're not increasing the capacity that all the resources given to NITAGs. The EPI resourcing remains the same, and it's all these, they are all the stakeholders that are required to use these tools. So as we talk about optimization of the portfolio, do we need to look whether the way the countries are set up to undertake all these processes, they are well equipped and well resourced?
Thanks, Ben, for the excellent question. And I think there's, we may present guidance and tools in these webinars and a process, but to me, there's really a shift in the mindset as well that is needed and that will take time. And so I think there are assumptions on timelines and countries' ability to really assess those trade-offs, and particularly when it comes to budget impact and budget analysis, that will require some time. I'm not sure this is going to be as straightforward as it may look on slides for all countries. And I think to your point, I think the guidance continue to evolve, and the capacity of NITAGs to absorb and really support basically the use of this tool and really own basically this methodology. I think is a very fair question that is being asked, especially in a context where NITAG members are also most of them fully working and doing this NITAG work in addition to their day-to-day jobs. And so, to your point, Ben, I think these are the questions that are being asked. What type of support? What type of consideration? To be fair, also, I think we have the chance on immunization relative to other programs, such as STB or HIV, where we have NITAGs established in most countries, functioning and able to support this evidence-informed decision-making process. So I really hope that with the appropriate support and with enough time to build this capacity, we can really move towards this approach where countries and NITAGs are able to review a number of options and to prioritize amongst them. We've tried, as you know, as much as possible to create links with the ETR process and the criteria, the evidence gathering. But of course, this is a big mindset shift in mindset that will require some time to be fully integrated and taken forward in my view. And I think building on the learnings, documenting countries' experience and lessons learned, including challenges, will be essential.
Thanks, Johanna. And just for people to note, please just check the chat. Laura's put in a comment there indicating that it would be useful to hear from countries as to what support will be useful with these processes, and a request to complete the form that was shared earlier. So please, participants in the webinar, can you please just look at that last comment from Laura and click on the link and make some comments. There's a poll as well.
Yes, Greg, thanks for noting that. So maybe just to say that we do have a poll and it'll stay up until just after the end of the session, but it's also very useful feedback for us. So please do complete it, but not to let it distract you from asking questions. But I think
can we just leave the poll for a minute or two and finish the questions?
You can just minimize it to the bottom of your screen for all attendees, and then we've got about 5 minutes left for Q&A.
Okay, no, thanks, Ramonde. I think that there were the optimization of 10 dose to 5 dose measles is obviously a very interesting issue. And there's a question from Georgina Tember, and I'm wondering if Dr. Ferrara would like to comment. What assurances are in place to guarantee sustained vaccine available when optimizing from 10 to 5 dose presentations? But we just had that discussion now, earlier on.
I think there might be another question that is
There
not
must be another
visible.
question.
And if I may read that out, I think it is also for Dr. Furaha. What are
Okay.
some of the key lessons for optimizing to switch from 10 dose measles containing vial to vaccine vial to a 5 dose? And there was another,
Yes.
which was, could you perhaps share the rationale and process you undertook for your country's decision to do that switch from 10 to 5 dose?
Yes, so thank you very much. So Dr. Georgina Temba is our program manager, and actually she was asking that question on behalf of Tanzania. As our colleague, as I'd mentioned earlier, Zanzibar had already switched from MR10 to MR5 doses, but we've seen a little bit of some delays in terms of getting that. So we really wanted to ask that in terms of market availability and what will be the issues in terms of sustainability. That's where the question is originating. So coming back to the rationale of what we switching from MR10 to 5, so there were different issues that we'd thought of. One is the reduction in terms of wastage, but at the same time also improving the coverage, especially in the rural and hard to reach areas. So we thought of 5 dose vial will minimize a lot of wastage, especially in particular those places with low or client turnouts, but also better alignment with session sizes, whereby in most of the outreach and low population areas have challenges in gathering 10 or less kits. And we thought a 5 dose vial will allow also the healthcare workers to be more comfortable and have more acceptance in terms of opening the vials, vaccinating the kids, as well as also minimizing the wastage. But also, this will better align with alignment with the session sizes, and also encourage coverage and accessibility, because there are a lot of missed opportunities that are happening with the 10 doses vial vis-a-vis having a 5 dose vial. And we've seen that example. We looked at the Zambia study, but also we had a example coming from Zanzibar, whereby it was very efficient, a lot of reduction in terms of wastage, but also good coverage in terms of MR, especially 1 and MR2. So that's the rationale. And coming to the lessons learned, of course, we had a very good lessons learned, especially from of course, Zanzibar counterparts, whereby we saw that training and clear guidance had a much reduction in terms of hesitancy, especially among healthcare workers in opening the MR vials, the 5 dose vial, but also reduction in the wastage as well as the gain in coverage in terms of vaccination. But as well, there was a strong monitoring of vaccination during the rollout, and also soon after that. And for mainland as well, the plans are still the same. We want to be a very structured approach, following the decision-making systems, to have a proper trainings, quality trainings in terms of healthcare workers, but also aligning well with the session sizes and able to have a good coverage, especially in the hard-to-reach areas, as well as the rural places. Over.
Thanks very much for those responses. Tony, just a quick question to you. You spoke about optimization in the context of changing a service provider and saving some money. But how about actually optimizing the actual schedule itself and moving from what we use in South Africa and in many other countries in Africa, a 2+1 schedule to a 1+1 schedule? which would make immunization against pneumococcal disease much easier and save lots more money. Any comments with respect to that?
So it's been interesting just watching the chat and the Q&A. Is that the point has been raised a few times. It's not just about how many doses you're wasting, and it's not just about cost. Of course, those are very important. But in the context of PCV, the recommendation from SAGE from June last year was that, and I'll quote here, countries or subnational regions, if they have well-established population immunity among children aged less than 5, achieved through mature 3-dose PCV program, achieving high coverage of at least 80%. So it can't just be made in a vacuum. You've got to be sure that you've got the other pieces of the jigsaw in place. And the one that I mentioned was ongoing serosurveillance. So yes, it's an attractive decision because you save money and you can fund other programs, but you've got to have the other pieces of the puzzle there. Thanks, Greg.
Okay, just for those of you who may not be familiar with the change in schedules for pneumococcal disease, there's been a very interesting trial just completed last year in the Gambia, where they looked at a 2-dose schedule versus a 3-dose schedule. And in fact, in the clinical trial, the 2-dose schedule was as effective as the 3-dose schedule. And the schedule's already been used in high-income countries. And there's been some data from Vietnam and South Africa indicating that in terms of immunogenicity, a 2-dose versus 3-dose schedule is equivalent. But folks, we're running out of time. We've got 2 minutes left, and we need to close this session on optimization. And I'm going to ask Laura Shimp to please take the floor and just end the seminar with a few closing remarks. Thanks very much, Laura.
Thanks so much, Greg, and thanks to Tony, Dr. Faraha, Joanna, and the team for the responses to the questions. First and foremost, thanks to all of you, the participants, for participating over the series of these webinars and for being actively involved in the chat, in the question and answer, and of course for completing the survey and the poll, which will really help us moving forward collectively as partners to be able to address some of the technical information needs, the reference and resource materials to be able to really help and partner with you in these processes of prioritization and optimization, which are quite complex, as we've discussed in the series of webinars. But also, we understand that you're under a lot of time constraint in having to readjust your decisions, not only just in terms of the prioritization and optimization of your own programs, but also given the resource constraints that you may be facing and the need for rapid decisions to maximize the efficiencies in your program. So today we really benefited from hearing the complementarity that can come between optimization and prioritization, with a really nice overview on the new tool unveiled today for the optimization that links with our previous discussions around the tool for prioritization, and really looking at how these two tools can help as resources for your programs. And thanks to South Africa and Tanzania for sharing really concrete country examples that can help us understand how optimization decisions have been made. And I think in both cases, they also highlighted how the prioritization and the decision-making processes need to be taken into account when you're looking at switches for your vaccines and trying to find those efficiencies. Really want to thank you all again for your active involvement. Please do let us know how we can assist based on what you put in the survey for us to be able to continue these discussions, which we know are going to be very active coming forward in the next several months. Please do not hesitate to reach out. Thanks again. Thanks so much to Niche, to Development Catalyst, to WHO, to UNICEF, to Gavi, to our own Choices partners for all of the support with this webinar and for making this happen, including over the holiday season. So thanks to all of you who've also participated, and hope that your 2026 is a good year and a prioritized and optimized year, shall we say. And thanks again to Ramonde and team for all of the coordination on this webinar. Thanks, everyone, and please have a good rest of your day, and don't hesitate to reach out. Thank you.
Thanks. Cheers.